Brad Spellberg is your LA County Chief Medical Officer. He oversees what's happening, that what goes for everybody. So we have consistency and standards. And he's going to talk on something this morning that's very important to healthcare. Come with an open mind to listen. Please don't think you know everything, because you're going to find this researcher. Okay, that's what he is. A top level researcher. Is also a USC professor in medicine. All right. And so know that his getting to where he is, the Tech Foundation put him in place to let that happen. So this organization itself, LA Veterans Collaborative, is also a special place. And it is a USC connected space. All right. Thank you for coming. And without further ado, Dr. Brad Spellberg.
Well, thank you very much, Louis. And indeed, this is an apolitical space. What's the line? I hate both sides equally. So we're not commenting on politics here. We're going to try to stick to data and fact. Why is there interest in revising or reforming the delivery of healthcare in the United States? I often hear people tell me that the United States has the best healthcare system in the world, that we have the most sophisticated healthcare delivery in the world. And the problem is that while it's certainly true that we have probably the most advanced technology in the world, and probably amongst the best trained providers in the world, that does not mean we deliver effective or cost-effective healthcare. If you look at third-party evaluations of the performance of our healthcare system relative to other industrialized nations, we rank 11th out of 11, which is not what we would consider to be good. Dead last is the opposite of good, okay? Now, you could say, yeah, but they're ranking us on a variety of aspects of healthcare delivery. They're talking about equity and efficiency, but we deliver the best outcomes, right? No, when you look at outcomes, we are 11th out of 11. I'm talking about death, people. We are 11th out of 11 industrialized nations based on objective evaluations of data. We do not deliver effective healthcare in this country, despite technology and despite having the most advanced training of our providers, okay? If you look at attributable death that can be intervened on by the healthcare system, here were your rankings in 2004 and 2014. We were dead last then, and we're dead last now. Unfortunately, here's us at the end. We've barely advanced over the last decade, whereas our Western European competitors have all dramatically improved. We're stuck in a standstill, and the other industrialized nations, particularly in Western Europe, continue to improve. And this explains why, if you just look at life expectancy as a crude marker of how we deliver healthcare, we are in the middle amongst 50 nations, many of which are not highly developed industrialized countries. I mean, the good news is that we're ahead of the United Arab Emirates, but we're behind Chile and Greece, countries that we would expect, perhaps given the amount of money we spend on healthcare, that we might be doing better than, just based on how long we live. Again, objective data. That's not a political question. How long you live is an objective, measurable fact, and we don't do that well. There is, however, one category that we are the world champions in. And I don't mean like we're number one. We're like way number one. We're number one so far that number two is half of us. And that's how much we spend. As a cost as a percentage of GDP, we are hugely more expensive than any other country in the world. Here we are from a few years ago. Number one out of 51 countries. Look how far behind us number two is. This is cost as a fraction of GDP. Our GDP is enormously larger than all of these other countries. So this is an underestimate of how much more expensive we are than every other country in the world for not delivering very good outcomes. Again, this is an objective, measurable fact. There are some very sobering realities we need to come to grips with. We spend 18% of our gross domestic product on delivering healthcare. The next highest country amongst industrialized nations is France at about 11.5%. And our GDP is hugely larger than France. So in terms of dollar outlays, we're spending $10,000 per American life. For a human being in this country, $10,000 every year to deliver healthcare. That is an outrageous amount of money. $3 trillion of healthcare expenditures in this country is an outrageous amount of money. And if you want to just compare us to our Western European and Australia, New Zealand comparator groups, here's us and here's them clustering all in the 8 to 11% of GDP. And we're up at 18%. It's not even close. It's embarrassingly more money than everyone else. Again, this is just objective, measurable reality. The other scary thing is that our costs are going to get a lot worse in the coming 15 to 20 years. This graph does not look at all healthcare expenditures. It only looks at federal costs in the actual US federal budget. So it's not looking at private expenditures, not looking at state expenditures, it's looking at federal expenditures. Here we are now. This is how much of the federal budget healthcare currently eats up. Here's where it's projected to increase over the next 20 years. It's going to double. This is a national crisis. If you spend that much of your money on delivering healthcare, you have no money left to spend on anything else. And then if you really want to be scared, and again, this is a sobering graph. It's an objective fact. It comes straight from the Congressional Budget Office. This graph shows the amount of federal debt as a fraction of GDP. Oh, sorry, no, this graph shows total debt, and this graph shows debt as a fraction of GDP. Here's where we are in terms of debt. We're $20 trillion in debt in this country. $20 trillion in debt. If you look at our debt as a fraction of GDP, this is the end of World War II. And this is where we are now. It's like we've just fought a huge, devastating global world war. That is the level of debt in this country, and healthcare is driving that debt. So it is not an exaggeration to say that our healthcare costs have become a national security risk. You can't spend money on defense. You can't spend money on infrastructure. You can't spend money on food stamps or Social Security if it's all going to deliver healthcare and not delivering it very effectively. There's another thing that's unique about healthcare delivery in this country. We're the only country in the world that puts the cost of healthcare primarily on the backs of for-profit businesses. Okay? Businesses spend huge amounts of money for employee benefits to deliver healthcare. We're really the only country in the world that causes businesses to be the driver of healthcare costs. This does make our companies less competitive, and it is a job killer compared to companies that are based in other countries where those companies don't have to spend 33% of employee costs to buy their healthcare. And that led the Oracle of Wall Street, the great Warren Buffett, to say that healthcare has become the tapeworm of the American economy. It's crushing us. These costs are crushing us, making us less competitive, decreasing salaries and wages for our workers, and decreasing the number of jobs that we create because of the costs of healthcare delivery, not even delivering it effectively. So you say, well, why? Right? Because so I'm the chief medical officer at LA County USC, and my job is to ask why. I go around to various parts of the hospital and say, why do you do it this way? And you know how I know when I found something I can fix? Dead giveaway, 100% accuracy. If I look them in the eye and I say, how come you're doing it this way? And they say, well, we don't know, but we've been doing this way since 1978. I know they have a problem. If they can't tell me why, but it's just always been like that, that's something I can fix. So why? Why is it that the United States delivers health care by causing companies to pay for it? Was that an intentional design plan for healthcare delivery? No. This is a side effect, and it's very important that you realize that I'm not making this up. This is a side effect of a piece of legislation passed in 1942 to prevent post-World War II inflation. Like, I'm totally not making this up. That's really why our healthcare system works the way it does. In 1942, Congress and the president became very concerned that in the aftermath of World War II, whenever it was going to end, there would be an explosion of inflation, just like occurred after World War I. To prevent this, they passed the Stabilization Act. The Stabilization Act prevented companies from increasing salaries or wages. At the same exact time, those companies needed to lure people who hadn't traditionally been in the job market into the job market, because a lot of the people that were formerly in the job market were going in the army, and they needed to find other people to come into the factories and work the factories. Since they couldn't raise wages to lure people, what did they do? They invented benefit packages, and benefits were exempt from the Stabilization Act. The reason why companies offer healthcare insurance and dental insurance in this country is because of this act passed in 1942. So if we are basing our healthcare system on a piece of legislation that had nothing to do with healthcare, how can it possibly be true that our healthcare system is optimally designed? It's an accident. It's a side effect of a 70-year-old piece of legislation that had nothing to do with healthcare delivery. This is where I stop and say, oops, right? How can this be? We're spending $3 trillion per year on an accident that isn't even delivering effective care. Now, all that's about money and jobs and economy, and that's all good stuff. But, you know, Dr. Birnbaum and I took a Hippocratic oath to care for our patients, right? Where's the morality in it? Where's the morality of saying, you can't afford your health care? Oh, too bad. We're going to let you get sick enough that you have to come to the emergency room because we can't ignore you anymore before we provide you health care. Does that make any sense? Anybody think that's a good, rational way to deliver health care? It's completely against the Hippocratic Oath to deliver health care that way. And it also makes no financial sense. If I can spend $100 per year to keep you out of the emergency room, does it make sense for me to wait 10 years until you have to come in the ER and get hit with a $50,000 hospital bill? Makes no sense at all. Not only is this immoral, it doesn't even make financial sense. So the good news, if there's some good news, is there's a win-win possibility here. If we redesign our system, we can deliver more effective, more moral care for much less money. Who's going to say no to that? Politics aside, doesn't that sound good? I like this quote. I call Ben Franklin the first health economist. An ounce of prevention is worth a pound of cure. We can spend much less money up front to keep you healthy than we're going to have to spend if we ignore you till you get sick enough to where we can't ignore you anymore. Now, I hear this one a lot when I talk to people. I've actually heard congressional staffers say this to me when I've talked to them about healthcare. Well, why would you want to disrupt the job market? Why would you want to disrupt employer-based health insurance? It's working for us. Interesting, working for us. Well, it's working for us the same way that sort of like New Year's resolutions work for us, right? Like we keep doing them. They're happening. But that doesn't mean they work, right? We have a system that happens. I will grant you that. It does happen, but it doesn't work. Just because we do it doesn't mean it works. Just like New Year's resolutions. We do them, but they don't work, right? So this is not a good excuse. Don't tell me that we shouldn't muck with the system because it's quote unquote working when I've just told you it is far more expensive than any other system in the world. It delivers bad outcomes, and it wasn't even intentionally designed to be this way. It's an accident. We should keep doing it because we've been doing it? No, as I've told you, when I go into the hospital and I say, why do you do it this way? And they say, I don't know, it's been that way since 1978. I know I should fix it. That's a dead giveaway to a broken process. Let me give you a real example, and I'm going to, upfront for confidentiality reasons, let me just make real clear. This is not a patient that I took care of. This is not a patient that was seen at my hospital or at any hospital in the neighborhood around where my hospital is. I learned about this patient through roundabout ways. This is a patient who really exists, who is cared for at a hospital somewhere in the state of California. He is a healthy male, 50-year-old. He was in town for a conference, and he developed an infection on his face, a skin infection, while he was in town. And he went to the emergency room, and they looked at him. He had normal vital signs. His heart rate wasn't up. He was a little low-grade temperature, but his heart rate wasn't up. His blood pressure was okay. And he just had this painful, inflamed red area of skin on his face. They admitted him to the hospital to give him intravenous antibiotics and fluids. He was seen by multiple physician specialists, including a plastic surgeon for some reason. And he received an itemized bill at discharge. That itemized bill had more than 50 line items in it, capturing costs. Okay? Every day he was in the hospital, he got IV antibiotics infused. The wholesale cost of those antibiotics was about $20 a day, but he got charged $500 for the cost of those antibiotics. That's just for the drug cost. He also got charged $2,000 per day for the act of infusing the drugs through his IV. Just the act of the infusion, $2,000 a day. And he got lab tests charged to him for $2,000 a day. His total hospital bill was right around $50,000. And he had reasonable healthcare insurance, private healthcare insurance with a $5,000 deductible. So he got hit with a $5,000 medical bill. I'm not even sure he needed to be in the hospital. If I saw him in the emergency room, I would have discharged him with oral antibiotics, and the whole thing would have cost $300. That's our healthcare system at work. So I'm going to try to switch to a video that underscores a really important point. Look, bear with me as I try to make the technology work.
Oh. Yeah, this is Jerry Seinfeld. What? $2,800? That's the estimate on my car? No, don't even do anything. I'm going to think about it. Okay, bye.
So think about it. Putty says it's what it is. It's what it is. He's not going to cheat you.
Except it's not Putty.
What happened to Putty?
We had a little fight about the move. I took it to this other place. I think they might be trying to screw me.
Well, of course they're trying to screw you. What do you think? That's what they do. They can make up anything. Nobody knows. By the way, you need a new Johnson rod in here. Oh, Johnson rod. Yeah, well, you better put one of those on.
All right, folks, here's the thing. I did not go to medical school to tell patients they need new Johnson rods. And you just witnessed the patient who was sold an awful lot of Johnson rods that he didn't need. And it cost him $50,000, of which $5,000 came directly out of his pocketbook. When I go into the room to see my patients, I don't want them worried that I'm a car mechanic out to charge them money for things they don't need. And when I go see my doctor, I sure as hell don't want them trying to do that to me as a patient. Do you? Is this a rational way to deliver health care to our patients? Does this seem right? I think the Johnson rod analogy, that's one I keep using, is really important. If you're in a fee-for-service mode And the incentive is to do more things. The incentive is to make up things so I can get paid more money. That's not the right way to deliver healthcare. If you look at the cost of the expansion under affordable care, Medi-Cal expansion under affordable care in the state of California. Remember, Medi-Cal is to provide health care for poor people, for working families. For-profit companies made $5 billion in profit from expanding care to the poor people in the state of California. That is appalling. I love this quote from one of the faculty members at the USC Schaefer Center for Health Economics. The LA Times quoted him as saying, "Wow, those profits are gigantic." Yeah, you think? $5 billion in 3 years to provide health care to poor people. That's pure profit. This is not the way to deliver health care to population. And it explains, or is at least another example of why we spend far more money than any other country in the world and don't even deliver good outcomes. Bottom line, apolitical. This is just an objective reality. This is just a statement of fact. The US healthcare system is far more expensive than any other healthcare system in the world. And it delivers at best middle of the road outcomes. In some areas, even worse. But even just based on death, middle of the road outcomes compared to many countries that we would look at and think that's not even really a fully industrialized country. How could we not be doing better than them? It's also profoundly frustrating for patients and their families. I mean, my goodness, anyone who thinks that our healthcare system is efficient has never had to go through our healthcare system. And I think you all know what I'm talking about. Now, we have two forms of universal healthcare in this country. They're universal for specific patient population. Okay, we have the VA system. If you're a vet, you get your health care, period. And we have Medicare. If you're 65 or older, you get your health care, period. Those are the two subsets of universal health care in this country. Other patients do not have access to those packages, right? In other countries, those equivalent systems would cover everybody in the country, right? So the question is, are there ways for the US to move to those international models, to expand a VA-style system or a Medicare-style system to cover everyone in the country? Internationally, most universal systems are paid for primarily via taxing, okay, via taxing the population. But there are mixtures of private expenditures in there in various blends depending on the country. So the US is the one that's by far the most expenditure from private sources, and that's from employers, as we've discussed. But there are other systems, like even in Canada, where everybody thinks it's fully socialized. That is not true. There are private forms of insurance in Canada. And in other countries, there are exchanges, sort of like the Affordable Care Act, the German model, for example, where everyone has to have coverage, but that coverage is funneled through private exchanges. So it could be any of a mixture of ways. There isn't one way to deliver universal health care is the point. And we don't have to politicize this because there's dozens of models out there that already exist and already work. The one point I will make, and again, I think this is just a statement of fact, it's an apolitical reality. If you look at countries that have universal systems and how they perform, the countries that have more private contributions generally tend to deliver less efficient, less effective healthcare. So the Canada, German, France model tends to underperform the UK, New Zealand, Australia model. And the UK, New Zealand, Australia model tends to be primarily public-based insurance, but you can buy private supplemental insurance, sort of like a Medicare Advantage. The reality is, the more you interject private markets into the system, at least in international models, they tend to get a lower return on investment for their value, or lower value for the money invested. The term single payer is a loaded term, and it has become in some people's minds synonymous with universal healthcare, but it is not. Single payer is one way to deliver universal healthcare. It is not the only way. In a single payer system, the government provides insurance to everyone, and generally speaking, private insurance companies are not allowed to offer base levels of insurance, basic packages. There is, however, nothing that precludes them from offering supplemental insurance packages, even in a single payer system. That is different, for example, if you look at the UK system, which is more like the VA system where the government owns the hospitals, employs the doctors. That is a very different system than if you look at other international systems where it's more Medicare based, where you have an insurance plan, but you get to go pick your physicians and you get to go pick the hospitals where you go, and the doctors are not employed by the government. You can do this a number of different ways. And it is not constructive to get hung up on terms like single payer. Let's figure out the most effective, most efficient way to deliver health care to the most people for the least cost. I think I've already said all this. Okay. Now, let me talk about the single payer bill. And Dr. Birnbaum, who's here with us today, knows even way more about this than I do. But I want to make a few points about the single payer bill that was introduced in the State Assembly a year ago and has been hotly debated since then. There has been a variety of media coverage of this bill, which has indicated that it is unaffordable, that it will cost $400 billion to implement. And of course, how could the state possibly come up with $400 billion? Now, again, I've already told you, I hate both sides equally. So this is an apolitical commentary. If you look at the economic analysis that was done of the bill, it was done by a very widely respected professor of economics at the University of Massachusetts, who is also apolitical. He had no stake in the game. His analysis was that the current total money that California spends already to deliver health care to people in the state of California is $370 billion per year. We're already spending that money to deliver health care. There have been other analyses that have suggested that is actually a conservative estimate, and that the state may spend up to $400 billion on healthcare already. And with that expenditure leaves 8% of the population completely without insurance, despite the Affordable Care Act, and another 25 or 35% of the population underinsured, meaning they have catastrophic coverage only, but they don't have basic coverage and will often choose to forego coverage so they don't have to spend out-of-pocket money. That's not very good insurance. So we're spending $370 billion a year now to leave 8% of the population uncovered and another quarter of the population not very good insurance. It is true that if we took the current system and expanded it to cover the 8% who are not covered, the estimate was that would cost an additional $30 billion per year. That's where the $400 billion number comes from that you keep hearing the media refer to. It's if you take the existing expenditures, which is already $370 billion, and you add 30 more to it, you get to a total of 400. That's not 400 billion new dollars. It's 30 billion new dollars to cover everybody who's uninsured if you don't change the system. However, every healthcare economist in the world agrees that single-payer systems are more cost efficient than non. You will reduce expenditures moving to a single-payer system. Why? There's a variety of reasons, but the two most obvious are, one, you eliminate the for-profit motive. I just told you for-profit companies made $5 billion in profit to provide health care to the poor in this state. You eliminate the profit, right? So that's money that you take right off the table. It also eliminates the unbelievable bureaucracy behind healthcare delivery. You all know what I'm talking about. Anyone who has had a relative, loved one, or yourself through the healthcare system, all the forms you have to complete and the prior authorizations and the approvals for this, that, and the other, and bouncing stuff around is all waste. And the estimates are that it's probably 20 to 30% waste in our system that all goes away if you move to a single payer system. The economic analysis Dr. Pollan conducted took a conservative view and said if you move to a single payer system, you will reduce costs by 18%. The real number is probably much higher than that, but he took a conservative view of 18%. So if you reduce our healthcare expenditures today by 18%, he found you could spend $330 billion and cover everyone fully, which means we cover the 8% uninsured, we fully cover the other quarter of the population that's underinsured, and we actually spend $40 billion per year less than we're spending today. We don't need more money. We need to take the money we're spending now and spend it more intelligibly. That's the point. The real question is not where do you find $30 billion in new money, because you don't need to find the new money. It's in the system. The real question is, how do you move an entrenched healthcare delivery system that dates back to a 1942 piece of legislation that had nothing to do with healthcare delivery and switch from an employer-based system to a system where the public pays the bill and employers and employees no longer take it out of their paycheck. So the idea is, I'm going to get to the idea that has been floated is that if you put in about a 2.3% gross receipts tax and a 2% sales tax that exempts things that you need like utilities, the things you need to live, this would come up with the funding to replace employer insurance. That means the employers no longer buy your insurance and you no longer have to contribute from your paycheck for your insurance. You get all that money back. You should get a raise and your company will actually retain more of its revenue and should be able to hire new employees because they don't have to foot the bill for 33% benefits anymore. It's like a relief of 33% employment tax. In return, you say to the general population, 2.3% sales tax, 2.3% gross receipts tax. That comes up with the funding to replace the employer contributions to buy health insurance. So it is not more money, it is shifting around where the money comes from and actually will allow us to spend less money to cover more people in an actual thoughtful process, as opposed to we're doing this because in 1942 Congress passed a bill that had nothing to do with healthcare delivery. We're running short on time and I want to leave time for questions and comments. So I think really that's what I want to leave you, okay? Our current system was never intended to deliver healthcare. It is a side effect. It is an accidental outgrowth of a piece of legislation passed during World War II to prevent inflation that had nothing to do with healthcare delivery. It has created a system that is vastly more expensive than any other healthcare system in the world and delivers bad outcomes for that enormous amount of money. It is time for us to rationally rethink how we deliver healthcare in this country. That's my final thought, and I'd love to hear comments and questions from the audience. Thank you. Yes.